the second part of this session, and it is, as I have said, concerned with the value of CT scan in the diagnosis of chest conditions. And first of all, you should know the indications for CT examination of the chest. They are a lot, but the most important one at all is this one, to assess an equivocal plain X-ray finding. You have seen many cases in the chest X-ray, the pathology is not reached, or the diagnosis is not reached without the help of a CT scan. Like the nodule, which is a bronchogenic carcinoma, the mass, which is metastasis, for example, or bronchogenic, and so on. But from the plain X-ray, you can reach the diagnosis of pneumonia, you can reach the diagnosis of an abscess, you can reach the diagnosis of a tuberculoma if it has the specific findings. Also, one of the important issues is the diagnosis of suspected pulmonary embolism. This is a very important role for the CT scan nowadays. If you know that the pulmonary ventilation perfusion scan is obsolete, and also the pulmonary angiography is also obsolete, then I will show you how this can be performed in an easy way. In order to have a CT scan of the chest, you should put the patient on the CT machine and obtain this image. This image is known as the scanogram or the scout view. The value of this scout view is that you can say to the machine, I would like to scan this area from the apex of the lung down to the costophrenic angle. Then any machine should ask you about the thickness of the section. Would you like to have a 1 centimeter slices, or a ½ centimeter slices, or 3 millimeter slices? And we usually scan the chest of an adult every 1 centimeter scan interval. Then after having the sections in the chest, and you should display each section 2 times. One in the what we call the mediastinal window, where you can see the mediastinal structures. And the other one is called the lung window, where you can see the lung details. This shows the lung but not the mediastinum, and this shows the mediastinum but not the lung. Then if you have one of the modern machines, like the multi-detector, I will talk about to you in a moment, and you can order the machine to reconstruct the transverse sections into vertical sections, either in the coronal plane, as you can see, or in the sagittal plane, as you can see. These reconstructed images are very helpful in the diagnosis of chest conditions. Then the patient, if the patient is going to be injected with intravenous contrast, he should fast for about 4 to 4 hours. If you don't need to inject the contrast material during the scan, then you don't need fasting. What are the conditions whenever you don't need contrast material? These conditions: whenever you are looking only to the lung, in cases of assessment of diffuse lung disease, assessment of bronchiectasis, screening for lung deposits, and in some cases of Crohn. But if you are concerned about the mediastinum, then you should inject the contrast material to stain or to enhance the vessels in order to reach the diagnosis. Then I will give you a very quick idea about the development of the CT scan. This is the CT, the older machine, and any CT scan is composed of a big box, which is known as the gantry, and a bed where the patient lies. If you open this box or the gantry, and you can see a lot of instruments, and the most important one is the X-ray tube. And in front of the X-ray tube is the imager, which is known as the detector. The detector and the X-ray tube, and the patient lies in between these 2 parts of the machine. In order to have a section in the human body, the tubes should rotate and the detector a full circle. And this could not be obtained in the older machines because the tube is connected to the ground by electricity cables. Then the tube has to rotate half a cycle and goes back to parking, then rotate the other cycle and goes back to parking. By this motion, 4 motions in order to have a single section in the human body. And at that time, the CT scan of the chest was performed in 60 minutes. After that, the development of the spiral CT occurred in 1986. And by the spiral CT, we mean that the tube can rotate around the patient without stoppage, because the electricity is delivered to the tube without cables. Then the tube rotates continuously, and the patient, the bed where the patient lies also move while the tube is rotating. Then the patient, the bed is moving and the tube is rotating, and you got this spiral. And hence the name, the spiral CT, by this spiral. And this machine has decreased the scanning time of the chest from 60 minutes to 12 minutes. And it was a very good achievement in the radiology practice. After that came the most recent machine, which is known as the multi-slice or the multi-detector machine. In the spiral CT, you have an X-ray tube and a detector in front of the machine, then in the front of the tube. Then every tube rotation, you got a single section. Every tube rotation, you got a single section. What happens if you put in front of the machine, of the tube, more than one detector? Let us say 4 detectors. Then every tube rotation, you got 4 sections. Every tube rotation, you got 4 sections. Then by this machine, you can perform the CT scan of the chest in 3 minutes, decreasing the time to the quarter. Okay, and by this time, the detectors have been tremendously increased in front of the X-ray tube. And we have nowadays the 4-channel, the 6, the 10, the 16, the 32, the 64, 120, 80, 256, 320, 640. Then the most recent machine is 640 detectors in front of the X-ray tube. That is to say, every tube rotation you can have 640 sections in the human body. And by this time you can scan the whole body from head to toe in a second, or even less. Then can you imagine the very rapid scanning technique we have? And what is the value of these machines? Actually, in Egypt we have only the 320 machine. I think here also the 640 is not yet in the Middle East. Okay, there are 4 advantages. The first one is the very rapid scanning. If you have in your hospital, like us, a patient overload, and you would like to scan so many patients per day, and you can scan about 40 patients in 2 hours using this multi-detector machine. Then the vascular imaging. You can see any vessel in the human body just by injecting contrast material intravenously and let the machine to scan the area you would like. I will show you some images like this. Then the vertical reconstruction, you can reconstruct the images in any direction, and the virtual endoscopy, and you can go through any tube in the human body, like the colon, like the bronchus, like the ureter, like the esophagus, like the cochlea, using this virtual technique, which is almost similar to the real endoscopy. Then can you imagine that this is a CT scans of the chest, and you inject the patient with contrast material and let the machine to scan for the pulmonary artery, what we call CT pulmonary angiography. And you just mention to the machine, I am looking for the pulmonary artery, and the machine knows the time between the injection in the antecubital vein and reaching the pulmonary artery. Then whenever the dye reaches the pulmonary artery, the machine starts scanning, then you got these images. And you can reconstruct the images. You can see the most distal pulmonary artery branches, and you can see the minor, very small thrombus in any of these branches. And you can display the images in color, as you can see. This is an example of pulmonary embolism. This is the patent artery, this is the thrombosed artery, and this is the infarcted area in the lung. And the machine has the advantage of extraction of any undesired structure in the image. Here you are interested only about the pulmonary artery and its branches. And you don't need to have the ribs, the lung, the spine, the esophagus, and so in the image. Then you can remove all these structures and you are left with only the pulmonary artery and its branches for easier assessment. And this is the CT scan of the heart reconstructed in a 3D way, and you can see the coronary branches, and you can even remove the heart itself from the image, so you are left with the coronary branches. Also, you can see the coronary artery from its origin to its termination using this technique, which is known as curved reconstruction. You can reconstruct any artery in the human body as a single line. Then you can assess for the stenosis, for obstruction, and so. And here you can see the aorta. This is the ascending arch, descending aorta, abdominal aorta, aneurysm in the aorta, atheromatous calcification. And you can magnify the image, and you can look from the image to the image from the lateral view to see the posterior and the anterior aspects of the aneurysm, and you can display the image in color. Also, in the lower limb, you can inject the contrast material intravenously and scan the lower limbs. Then you remove the bones and remove the muscles, and you are left with the vessels. This is an example of a patent vasculature, and this is an example of an obstructed femoral artery at the level of the adductor canal. And can you imagine also that this is a CT image of the femoral artery, and we reconstructed the image in a 3D way, and you see this is the superficial femoral artery, which is included here, down to there, and then you got to the popliteal artery or the distal part of the femoral. Also, you can see the mesenteric circulation. Any vessel in the human body, the portal, whether it is vein or artery, and you inject contrast material, you name the vessel to the computer, and you scan. Then this is the superior mesenteric artery and the branches, and you can see the intestine. You can remove the intestine, and you can see the structures. Now let's look to the chest. In the chest, we have two sections, the mediastinal section and the lung section. Then, at first, we look to the mediastinal anatomy. And we have an anatomic landmark in the mediastinal anatomy and an anatomic landmark in the lung anatomy. The anatomic landmark in the mediastinal anatomy is the arch of the aorta, which is known as the banana by most of the chest physicians. The chest physicians usually call this as the banana. Then, starting interpretation, the CT scan of the chest, you should put your finger on the banana. And this is the arch of the aorta. Then look at this image, and you can see the arch of the aorta. Adjacent to it is the superior vena cava. Then this is the superior vena cava, and this is the anatomy at the level of the banana. Then what happens if you go up? And you see this is the arch of the aorta, and this is the superior vena cava. Upward, you can see the branches coming from the arch of the aorta, and they are three. The left subclavian artery, the left common carotid, and the innominate artery. They are aligned in the same way, exactly similar to the arch of the aorta. Then you also see the left innominate vein crossing the midline to join the right innominate vein to form the superior vena cava. And this is the left innominate vein crossing the midline to join this right innominate vein to form the superior vena cava. If you go more up, the anatomy is the same. The branches coming from the arch of the aorta, left subclavian, left common carotid, innominate artery, left subclavian, left innominate vein, right innominate vein. Left innominate vein crossing the midline, they join to form the superior vena cava, and this is the arch of the aorta. This is the anatomy above the level of the arch of the aorta. What is the anatomy below the level of the arch of the aorta? Here you are cutting in this area. This is the ascending and then the arch of the aorta and the descending. In this area, you see you are cutting here. This is the arch of the aorta and the superior vena cava. Now, if you go a little bit down, the arch of the aorta will divide into the ascending aorta and the descending aorta. This is the ascending aorta, and this is the descending aorta. And if you go more down, then you can see the ascending aorta and the descending aorta with a gap where the pulmonary artery will appear. And this is the ascending aorta, this is the descending aorta, and this is the pulmonary artery, which looks like the figure of 8 in Arabic. And you see, this is the main trunk, this is the left branch, and this is the right branch. And you remember that this is the superior vena cava. Then, if you go to the same anatomy, and you can see this is the superior vena cava, this is the ascending aorta, this is the descending aorta, and here will appear the pulmonary artery. And then if you go down, then you can see the pulmonary artery, like the figure of 8 in Arabic. This is the main trunk, left branch, right branch, ascending aorta, descending aorta, and the superior vena cava. The same anatomy, this is the pulmonary artery. Main trunk, left branch, right branch, ascending aorta, descending aorta, superior vena cava. Then every one of these branches should enter a specific cardiac chamber except for the descending aorta, which will go into the abdomen. Then the superior vena cava will enter the right atrium. This is the superior vena cava, this is the superior vena cava, and the beginning of the right atrium. And this is the superior vena cava and the right atrium. The superior vena cava entered the right atrium. Then go to the pulmonary artery. This is the pulmonary artery, will enter the right ventricle. This is the pulmonary artery entering the right ventricle. The pulmonary artery entered the right ventricle, and this is the right ventricle adjacent to the right atrium. Then go to the ascending aorta, which will enter the left ventricle. This is the ascending aorta, ascending aorta, ascending aorta, ascending aorta, and this is the left ventricle. The left ventricle is adjacent to the right ventricle, which is adjacent to the right atrium, which is adjacent to the left atrium. This is the left atrium, this is the right atrium, right ventricle, left ventricle. Come to the same anatomy, left atrium, right ventricle, left ventricle. Go down, left atrium, right ventricle, left ventricle. More down, left atrium, right ventricle, left ventricle. More down, left atrium, right ventricle, left ventricle. And this is the entrance of the inferior vena cava coming from the abdomen to join the right atrium. And this is the dome of the liver and the diaphragm. Then you have finished the mediastinal anatomy, and I will repeat it once more. But go to the lung anatomy. How can you know where is the upper lobe, where is the middle lobe? Is an easy way. Just remember that your landmark here is the trachea. And this is the trachea, which is filled with air. Whenever you see the trachea, you are cutting in the upper lobe, okay? And the X-ray film or the CT scan section is just a patient looking to the physician. Then this is the left side of the patient, and this is the right side of the patient. Then you see the trachea, this is the left upper lobe, and this is the right upper lobe. Okay, then you go for this section. Can you see the trachea? Yes. This is the trachea, then this is the left upper lobe, and this is the right upper lobe. Okay. What happens if the trachea has divided into two main bronchi? Whenever the trachea divides into two, the section is divided into two. Then look at the section on the plain X-ray. And at this side, you can see part of the upper lobe anterior and the lower lobe posterior. Part of the upper lobe anterior and the lower lobe posterior. Then, when the trachea divides into two, the section is divided into two. The anterior part belongs to the upper lobe, the posterior part belongs to the lower lobe. Then look at this. The trachea is divided into two. Then the section is divided into two. This is the upper lobe. This is the upper lobe, and this is the lower lobe. Okay. Then after you go down, more down, no trachea, no bronchi, you are in the region of the cardiac shadow. In the region of the cardiac shadow, you are cutting here. Look on the right side, this is the upper lobe, this is the middle lobe, this is the lower lobe. Part of the section is the middle lobe, and part of the section is the lower lobe. On the left side, part of the section is the lingula, which is part of the upper lobe, and the rest of the section is the lower lobe. The lingula and the middle lobe is about 1/3 of the thoracic diameter. Then I draw a line like this, putting a 1/3 anterior and 2/3 posterior. The anterior third on the left side is the lingula. The anterior third on the right side is the middle lobe. The posterior 2/3 on the left and on the right belongs to the lower lobe. Then, what do you think about this section? We have three levels. The level of the trachea, the level of the main bronchi and the level of the heart. At what level you are now? The second level, the main bronchi. Then, whenever the trachea divides, the section is divided. Then, what do you think of this area? Left upper lobe. And what do you think of this area? Right lower lobe. Then came to the cardiac shadow. Can you see the fissure? This is the site of the fissure where exactly I draw my line, separating the anterior third from the posterior 2/3. Then what do you think about this area? Middle lobe. And what do you think of this area? The lingula. And what do you think of this? Lower lobe right side. And this? Lower lobe left side. And this? Lower lobe right side, actually, because it is posterior to the fissure. Then, and you see an area of consolidation with air bronchogram. Where is this area in the lung? Left upper lobe. Very good. This is the left upper lobe because the trachea is divided. This is the upper and this is the lower. Very good. What do you think about the site of these bronchoectatic changes? Right lower lobe. Very good. The trachea is divided. This is the upper lobe and this is the lower lobe. What do you think of this mnemonic patch? Lingula. Very good. This is the lingula because this is the cardiac shadow and the anterior third is for the lingula on the left side. What do you think of this nematocele? Right lower lobe. Very good. The trachea divides. This is the upper and this is the lower. What do you think of this bronchogenic carcinoma? You see the trachea, then you are in the upper lobe and this is the left upper lobe. Very good. What do you think of these pulmonary deposits? Right lower lobe and left lower lobe, both lower lobes. Very good. What do you think of these pulmonary tuberculous infiltrations? Lingula. What do you think of this tuberculous cavity? Right lower lobe. Very good. Then, do you remember the name of this? This is the banana, the arch of the aorta. And this one? Yes, this is the superior vena cava. And this patient had radical mastectomy on the right side with irradiation followed by fibrosis. Where is this fibrosis? This is the right side, right upper lobe. Because the trachea is divided, this is the upper lobe and this is the lower lobe. Very good. Then do you remember the name of this? Yes, the pulmonary main trunk. And this one? Ascending aorta. And you remember this one as well? Descending aorta. And this one? The superior vena cava. Okay. Do you remember this one? Superior vena cava. And this one? Ascending aorta. And this one? Pulmonary trunk. And this? Descending aorta. Very good. And what do you think the site of this bronchogenic carcinoma? Left lower lobe. Very good. The left lower lobe because the trachea is divided and this is the upper and this is the lower lobe. Left lower lobe. And this patient had pulmonary embolism and 3 infarctions. This is the embolus and these are the infarctions. What do you think is the site of the infarctions? Yeah, this infarction in the left lower lobe and these? In the lingula, yes. And you see 1/3 anterior for the lingula and the middle lobe, 2/3 posteriorly for the lower lobes. Yes, this is right, lingula and left lower lobe. Do you remember this chamber? Right atrium. Very good. And this chamber? No, the right atrium is adjacent to the right ventricle here. This atrium is adjacent to the other atrium, and this is the left atrium, okay? This is the left atrium, and this is the right atrium. This is the root of the aorta, and this is the pulmonary artery entering the right ventricle. Okay, do you remember this one? The banana. And you remember its real name? Yes, the arch of the aorta. And this one? And this one? Yes, this is the superior vena cava. Very good, and thank you very much.